Bismillah ar-Rahman ar-Rahim. Good morning, everybody. I will talk to you about an important topic in cardiology that is emerging in the last few years and will be of interest in the coming years. This is cardiac amyloidosis. The title of the presentation will be how to suspect, diagnose, and treat cardiac amyloidosis. Why this topic of interest? Because cardiac amyloidosis is generally underdiagnosed in our communities, and last epidemiological studies have shown that many of our HFpEF patients might be having a cardiac amyloidosis. What is amyloidosis? Amyloidosis describes a group of diseases characterized by extracellular deposition of toxic insoluble protein. These are the amyloid protein. These are the amyloid sheets, amyloid fibrils, which are non-functioning proteins, harmful proteins, toxic proteins that infiltrate certain organs like the heart. They are causing disruption and dysfunction. So it's a pathological, it's a toxic, it's insoluble proteins. There are generally two main types of cardiac amyloid, either AL amyloid, which is the amyloid light chain amyloid, and the ATTR cardiac amyloidosis or cardiomyopathy, which is Transthyretin cardiomyopathy. A and A here means amyloid, L means light chain, TTR means Transthyretin, and it is cardiomyopathy. ATTR is the most important of interest to us because we found it a common disease. There are two types of it, which are wild type, ATTR wild type, which does not run in families, and the hereditary or the mutant type, which is ATTRM, which run in families. So these are the two types of the Transthyretin cardiomyopathy. What is the difference between AL amyloid and Transthyretin amyloid? AL amyloid is the story of the bone marrow, is the story of the plasma cells. So it's the amyloid proteins are formed in the bone marrow, in the plasma cells. They are misfolded mainly in the bone marrow and the plasma to form these protofilaments, and then the amyloid fibrils, which are deposited in different organs, including the heart. But the Transthyretin amyloid starts in the liver. It's formed in the liver. It's a tetramer. It's a tetramer. It's a four compartments tetramer. Then it's a split in the liver, also two dimers, two molecules. And then this dimer is split to monomers. The monomers misfold, these monomers misfold, and then form the amyloid sheet, the amyloid fibrils. So we have three steps. The first step is that the tetramer is dissociated to dimers, and then the dimer is dissociated to monomers, and the monomer is misfolded to form the amyloid fibril. Actually, 4 steps. So 1, 2, 3, 4. So interaction with these steps at any level can treat and prevent cardiac amyloidosis. So again, the light chain amyloidosis or AL amyloid. The light chains are produced by the plasma cells in the bone marrow. This is the plasma cell in the bone marrow, and the plasma cells form the amyloid fibrils, which are deposited in different organs, including the heart, causing cardiomyopathy, the nerve, causing polyneuropathy, the kidneys, causing nephropathy and nephrotic syndrome, and renal failure, and also the liver and the digestive system as well. The Transthyretin TTR, actually it was called before the prealbumin. It's mainly a transport protein that transports thyroxine and retinol, which is vitamin A. the homotetramer of transthyretin is at 127 amino acid monomers, 130 mutation described in the monomer. So this is the tetramer, transthyretin tetramer, and this is the dimer, and this is the monomers. These monomers are the cause of the development of cardiomyopathy and polyneuropathy and different symptoms. So if we interfere with the degradation of the tetramer or the dissociation of the monomer of the dimers or the folding of the or the misfolding of the monomers, all these steps can prevent amyloidosis. Is cardiac amyloidosis rare? AL amyloid is rare. It's a rare condition with an estimated prevalence of 8 to 12 per million. There are around 3,000 newly diagnosed cases of AL amyloid per year, 3,000 cases in the United States per year. But ATTR amyloid, on the other hand, have the autopsy data have demonstrated that among adults more than 80 years of age, 25% have transthyretin amyloid deposits in the myocardium. So this means that transthyretin cardiomyopathy is a very common disease in the elderly. Almost 1/4 of patients in the age of 80 are having cardiac amyloidosis. Even patients with HFpEF, which are diagnosed as HFpEF, autopsy data reveal amyloid deposits in 32% of those patients over 75 years of age, compared with 8% of those aged less than 75. So age is a limiting factor here, important to the prevalence of ATTR amyloid. This is why it was called before senile amyloidosis. Emerging data using nuclear scintigraphy have suggested that 13% of patients hospitalized with HFpEF may have ATTR wild-type cardiac amyloidosis. So clinical data also are available, not only autopsy data. So the wild-type transthyretin amyloidosis, it was previously called the senile systemic amyloidosis, SSA. The median age is around 74, elderly, presented mainly by cardiomyopathy, atrial fibrillation, and the conduction disease. Also, bilateral tunnel syndrome and spinal stenosis are the main extracardiac manifestation of senile amyloidosis or ATTR amyloidosis. Bicarpal tunnel syndrome, bilateral carpal tunnel syndrome, and spinal stenosis. The most common type of amyloidosis is this type, and the median survival after diagnosis is 3 to 4 years. So this is the pathology. It's a diffuse infiltration of the myocardium by the amyloid proteins, mainly causing, as you can see, LVH, diffuse LVH, small LV cavity, left atrial enlargement due to the service function. This is the hematoxylin leucine stain showing the wide spread sheets of amyloid between the myofibrils and compressing the myofibril. And this is the Congo red stain, which is specific for amyloidosis. So this is again the pathology is diffuse, involving the whole myocardium, as you can see, increasing the LV mass with or without dilatation, most probably without dilatation. And also atrial fibrillation is very common due to impaired left atrial function. Also conduction system affection is very common in the form of left bundle or right bundle or heart block even. Microvascular ischemia also is common due to compression of the microcapillaries. So the classic presentation of cardiac amyloid is what we call the voltage mass mismatch, or the low voltage ECG in cardiac amyloid. As you can see, the limb leads are typically showing a low voltage criteria, and the chest leads are typically showing a pseudo function pattern at least in V1, V2, and V3. This is an 81-year-old white male with biopsy-proven ATTR cardiac amyloid showing low voltage present in 50% of AL amyloid, 25% in ATTR amyloid. So it's not very specific in cases of ATTR, but very specific in for AL, or partially specific for AL, but not very specific for ATTR. Sometimes even we found 10% meet all of each criteria. Pseudo-infarction pattern present in about 50% in EL. As you can see, this ECG was proven to be amyloid, but it fulfilled the criteria for LVH with a strain pattern. So when you see low voltage, it's good. It's a very good sign, very good specific sign for cardiac amyloid, but not a very sensitive sign. So not every patient without this sign does not have amyloid. Those patients with even LVH pattern and the strain pattern are having amyloid. Conduction abnormalities is common in this patient. As you can see, there is first degree AV block, and there is also right bundle branch block, and there is low voltage as well in this ECG, despite the LVH that's clear in the echo with the septum around 1.7 centimeter and the posterior wall 1.6 centimeters. So it's concentric LVH, small cavity, left atrial enlargement, plus low voltage first degree AV block and right bundle branch block in this 50-year-old male with nephrotic syndrome and heart failure proven to be AL amyloid. Echocardiogram is the first thing to give us the prompt suspicion when we have the concentric hypertrophy with a small cavity, left atrial enlargement. Sparkling appearance in the echo is not very specific, but we found it commonly. It's not very specific for amyloidosis, but it raises the suspicion about amyloidosis. This is a 55-year-old male with nephrotic syndrome and heart failure. There is LV and RV thickening, atrial dilatation, thickened valve, pericardial effusion. All these can be a manifestation of cardiac amyloidosis, of course, plus the LVH. So the clinical presentation, the cardiac and non-cardiac manifestation. The cardiac manifestation is mainly half BEF. Sometimes aortic stenosis. Aortic stenosis could be a sign or due to cardiac amyloidosis. AFib, cardioembolic stroke due to atrial enlargement and atrial fibrillation. Heart block, first degree, or any kind of heart block plus bundle branch block, angina with normal epicardial vessels. Sometimes also are presenting symptom. Non-cardiac, mainly orthostatic hypotension due to autonomic dysfunction. This is very common. Plus peripheral neuropathy, autonomic neuropathy, and autonomic neuropathy is the cause of orthostatic hypotension. Bilateral carpal tunnel syndrome is a very important triggering symptom and raise the suspicion about cardiac amyloidosis, and also spinal stenosis, both of them in TTR. So bilateral carpal tunnel syndrome and spinal stenosis are the most important suspicion about TTR amyloidosis. This is the carpal tunnel syndrome, very related to the incidence of cardiac symptoms. But macroglossia and the periorbital perbora, like this man, is more with AL amyloid. So this is more specific for AL amyloid, not TTR amyloid. So how to approach the diagnosis? First, clinical. Clinical is the most important, heart failure, echo and ECG, or ECG and echo, and then imaging. Imaging usually cardiac MRI, echo with a strain, and a nuclear study called the technetium pyrophosphate scan for both the bone and the heart. For the labs, we do the serum free light chains, serum immunofixations, urine immunofixations. Of course, routine lab, especially heart failure biomarkers like NT-proBNP, especially and the troponin, very important. Of course, the last routine lab like kidney functions, liver functions, CBC, electrolytes, all these are important also as well. Biopsy for the transthyretin, usually we don't need biopsy, just we need the imaging, and then we do the genetic testing, either the wild type or the mutant type by genetic testing. And then to complete the lab, we should have the lambda and the Kappa light chains, and then to transfer the patient to hematology and oncology consult. The lab tests for workup for AL amyloid, serum protein electrophoresis and urine protein electrophoresis are rarely done now, but the most important is the Kappa free chain and lambda free chain, free lambda and free Kappa and free lambda in the serum, and the K/L ratio. The serum light chain ratio is very, very important. When it's very low like this is more diagnostic of AL amyloid. So this is mainly lambda free cardiac amyloidosis, AL amyloidosis. The cardiac MRI has a good sensitivity and specificity as well, but the nuclear studies are more important than the cardiac MRI. As you can see, diffuse LVH mainly, but sparing the apex. As you can see, the apex is not that affected like the base. So cardiac amyloidosis mainly, as you can see, affected the base symmetrically with small cavities and enlarged left atrium, as you can see. So this is the enhancement. As you can see, it's more mid myocardial, in the mid of the myocardium, not and the subendocardium, more subendocardium to mid pericardial, not in the epicardium. The specificity around 90%, but the sensitivity around 80%. So not every amyloid patient will have positive scan by MRI. The negative predictive value around 85%. Echo, as you can see again, diffuse, LVH, sparkling appearance, granular appearance of the myocardium with left atrial enlargement, as you can see. And the most important is the strain pattern, or the strain rate, sorry, the strain pattern, sorry, apical sparing. The apical sparing is, or the bull's eye, is a very specific sign for cardiac amyloidosis. When you see the apex is red, like this is the apex, more red. This is the base, more blue. This means we have apical sparing of the myocardium, which is a very specific sign for we call it bull's eye, which is very specific sign for cardiac amyloidosis. The most important test in TTR amyloidosis is the technetium pyrophosphate PYP 99M. The idea of the test is just we are comparing the cardiac uptake, myocardial uptake of the technetium to the bone uptake. So when the bone uptake is more than the cardiac uptake, like this one, this is grade 0. So this is not, there is no suspicion about TTR amyloidosis. When the cardiac uptake is apparent but less than the bone uptake, this is grade 1. When both are almost equal. This is grade 2. When the cardiac uptake of the myocardial uptake is bigger than the bone uptake, this is grade 3. Grade 2 and grade 3 are very diagnostic for TTR cardiac amyloidosis. As you can see, it's very important for diagnosing ATTR wild type and the ATTR mutant type, but not for AL amyloid. So diagnosis of ATTR cardiac amyloidosis, grade 2 to 3, grade 2 or 3, negative monoclonal lab testing, 91% sensitivity and 100% specificity for ATTR amyloidosis, 100% specificity for ATTR amyloidosis. So, but you should make sure that the monoclonal lab tests are negative, so there is no any suspicion about AL amyloid. You don't need to do any biopsy to diagnose ATTR amyloidosis, unlike AL, which you might need to do bone marrow biopsy, fat bed aspirate biopsy of the affected organ. Biopsy of the heart is very, very rarely done now for diagnosing cardiac amyloidosis in view of the recent investigation and recent imaging and recent lab. For the TTR, again, technician pyrophosphate, if the grade is 2 or 3 uptake plus negative monoclonal antibody testing, then you can do the genetic testing only to separate the hereditary type from the wild type of TTR. This is another case, a 78-year-old female has a history of hypertension, ejection fraction 45%, referred for shortness of breath. As you can see, there is multiple arrhythmias, and there is also, I think, wide QRS due to conduction abnormality. Is not typical for left bundle or right bundle, so interventricular conduction delay. The echocardiogram, as you can see, typical diastolic dysfunction pattern with concentric left ventricular hypertrophy and biatrial enlargement, as you can see. Most probably you will find also mild, moderate mitral and tricuspid regurgitation in those patients. And of course, the partly for the granular appearance, which as I said is not very specific. The TTR amyloid is diagnosed by the uptake, technician uptake. Here in this case, around 2, it's 2, so the bone uptake almost equal to the myocardial uptake. And for the AL amyloid, you need to have the free light chain determination and the monofixation of the protein. In this case, has no monofixation and normal light chain, free light chain in the serum. So this case was a TTR cardiac amyloidosis. It was hereditary type, اللي هو mutant type, Transthyretin cardiac amyloidosis ATTR mutant type. 61-year-old female with shortness of breath and edema for 1 year, urine with 9 grams of protein, and low voltage ECG, as you can see, or maybe pseudo-infarction pattern here in V1, V2. Serum troponin was mildly elevated or normal, but NT-proBNP was very high, 3,505. So this patient is having clear manifest heart failure, and this is the echo, and this is the typical strain showing spared apex and affected, symmetrically affected base, the ball eye, as I said before. So the light chain shows a very high serum kappa and a normal serum lambda, as you can see. And the ratio of kappa over lambda is around 13 and no monofixation protein. So this is typical kappa light chain AL amyloid. Kidney biopsy showed kappa light chain amyloidosis, and bone marrow biopsy showed only 1% plasma cells, Congo red negative, so it was a kappa light chain AL amyloid. So the diagnostic test here is the kappa free serum and the K over L ratio, plus the echo and imaging, but the bone marrow biopsy for this case was negative for plasma cell. What about this case? This is another 81-year-old white male with typical LVH and stream pattern. So the suspicion of amyloid is not present depending on the voltage mass mismatch, but echo revealed LVH, LV posterior was 1.6, and there is typical the surface function was bilateral atrial enlargement and mitral and tricuspid regurgitation, and echo revealed again the bull's eye, and TTR screening by technetium pyrophosphate scan was positive. With cardiac uptake of the tracer higher, even or equal to the bone uptake of the tracer, as you can see. And the kappa chain here was 41, not that high, yeah, just double the normal, but normal lumbar. And serum immunofixation, there was no M protein. This case was diagnosed as wild type Transthyretin cardiac amyloidosis. So the teaching points here is look at the ECG and wall thickness in the echo. This will help you to pick and suspect the cardiac amyloidosis plus the clinical presentation. Don't order serum protein electrophoresis or urine protein electrophoresis. Rather, order serum-free light chains. So serum-free light chains and immunofixation are the most important, either in the urine or the serum. Then technetium pyrophosphate scan is very specific for TTR. This is the most important test, to do the technetium pyrophosphate and to do the serum-free light chains and immunofixation in the serum and the urine. Serum protein electrophoresis and urine protein electrophoresis are of no benefit now. The red flags that you can see is older white male with previous carpal tunnel syndrome and historic heart failure or HOCM, or old African American with the historic heart failure. Ask about both carpal tunnel syndrome and the spinal stenosis in any history taking in those patients. Don't forget carpal tunnel and spinal stenosis. This is the most recent algorithm. I like it for patients with cardiac amyloidosis suspicion. If you have clinical suspicion of cardiac amyloidosis, depending on the history and the clinical exam and the ECG, plus the echo, then you have these two options. You have to order the free light chains, serum free light chain ratio, serum immunofixation, urine immunofixation, plus technetium pyrophosphate 99M scan. If it's AL amyloid, you will find abnormal serum free light chain ratio. If it's high, above 1.65, it's kappa. If it's low, below 0.62, it's lumbar. No M protein spike on immunofixation, and grade 1 or 0 myocardial technetium pyrophosphate. This is very important. So there is no or less than bone myocardial uptake of the radio tracer. If it's ATTR, what you will find normal serum free light chain, free serum light chain ratio. You will find it at normal ratio. So these numbers are not here, and there is no M protein spike on immunofixation. and there is grade 2 or 3 myocardial technetium pyrophosphate uptake equal or greater than the bone. So grade 2 or 3 myocardial technetium pyrophosphate uptake. Endomyocardial biopsy most probably is not needed, but it's a diagnostic, it's the gold standard still. Usually we don't need it. But for AL amyloid, you might need bone marrow biopsy to confirm and quantify plasma cell clone. Genetic testing to determine mutation or wild type in case of ATTR. Let us get back for this case, because it looks like I was confused about this case. So again, this case was the ratio here was high, was 13. So the serum, urine, and there was no M protein. Kidney biopsy, kappa light chain amyloid. So the kidney biopsy was positive. Again, sorry, the kidney biopsy was positive for kappa light chain amyloid. So this was proved as kappa light chain amyloid, despite the bone marrow biopsy was negative. So this case again was kappa light chain amyloid. This is the most important scheme for diagnosis. Don't forget these two screening tests, technetium pyrophosphate and the serum free light chain ratio. So what are the red flags again? The red flags for cardiac amyloidosis is heart failure without clear etiology, the presence of LV hypertrophy, non-dilated left ventricle. This is the clues to early suspicion of cardiac amyloidosis. Patient with hypertrophic cardiomyopathy and the presence of pericardial effusion, very important pericardial effusion, AV block, interatrial septal and valvular thickening, and apical sparing, as I said before, very important. Low QRS voltage and LV thickness, very important. Or an elderly man with unexplained symmetrical LV hypertrophy, especially in the absence of hypertension. A history of bilateral carpal tunnel syndrome in a man with Hockham-like phenotype. What is the treatment of cardiac amyloidosis? Number one, treatment of cardiac symptoms. And this is very tricky. I will speak about it now. And then the proper treatment of amyloid itself, how to prevent the formation of amyloid proteins. The management of heart failure in cardiac amyloidosis. Number one, sodium restriction and diuretics to relieve congestion. Give them Lasix, give them, prevent them from eating a lot of salt. And also loop diuretics and spironolactone is the most effective. Beta blockers and ACE inhibitors are neither effective and nor well tolerated. So most probably those patients who are on the hypotensive side, they are not hypertensive, and they usually have orthostatic hypotension. So beta blockers and ACE inhibitors are usually not tolerated. Digoxin is usually avoided due to concern of increased risk of toxicity due to the kidney effect. So forget about digoxin as well. Maintenance of normal sinus rhythm is preferable due to the importance of atrial contribution to the cardiac output. So maintaining sinus rhythm and preventing or treating atrial fibrillation may be important. Anticoagulation in patients with AFib and even in patients with normal sinus rhythm is also important as well. Very important to treat, to give anticoagulation if the patient is having AFib on those patients. Even in patients with sinus rhythm, and evidence of big right-left atrium, better to anticoagulate them. No acts now makes our life easy. Pacemakers are indicated for heart block or symptomatic bradycardia, of course. The role of ICD is controversial, but may be warranted in certain patients with AL cardiac amyloid. Usually, I don't recommend the ICDs, but only pacemaker if the patient is having symptomatic bradycardia. What is the treatment? What is the proper treatment of AL amyloid? AL amyloid, the treatment is chemotherapy plus dexamethasone. dexamethasone to treat the plasma cells. Autologous stem cell transplant is very effective in patients with AL amyloid. But if there is refractory or relapsed cases, you might give monoclonal antibodies, has a role in treating those patients. Heart transplant for very selected cases with AL cardiac amyloid. Heart transplant results are not that good in patients with AL amyloid in general, but sometimes we do heart transplant for a very selected cases when the control of the general disease is perfect, and the only problem is the cardiac amyloid, then we might have heart transplant for some patients. For ATTR treatment, the target is to stop hepatic stenosis. So for ATTR, we have to clear therapeutic target. We might block the TTR senses from the start. So we might block the formation of the molecule in the liver at the translational level, the tetramer. If we cannot block the senses, we can stabilize the tetramer to prevent it from degradation to dimer and monomer. This is a very important sign. So either to block, either to stabilize it. يعني لو ما قدرتش تمنع تكوينه على الأقل امنع تكسيره. الستيب الثالثة, the third one, is to disrupt and clear the ATTR amyloid fibril, just to dissolve it. So this is the 3 steps: block the formation of the TTR, stabilize the TTR tetramer, and disrupt it after its formation. So this is the steps, as I said before, in the liver. This is the tetramer. So to prevent the formation in the liver and to stabilize the tetramer and to disrupt the amyloid fibril, this is the 3 steps. The first step, we call it silencers. Silencers are the drugs that suppress the hepatic TTR production. The one that stabilizes the TTR tetramer, we call it stabilizer, stabilizing circulating TTR from dissociation. And then the degraders, which are the which break down of the amyloid fibril tissue in the amyloid fibril tissue deposits. So this is examples of the drugs which are being used now and approved for the treatment. This is tafamidis, this is batisiran, this is RNA therapeutic agent for the treatment of hereditary transthyretin amyloid, and also this is inotersen for treatment of also hereditary transthyretin amyloid, the mutant type. And the tafamidis, the one which now approved by the FDA in this very important study, ATTR Act study, published in 2018. And for the first time, we have a drug that might decrease mortality as well, decrease all-cause mortality and improve the quality of life, decrease the decline in the 6-minute walk test and improve the quality of life, or reduce the decline in the quality of life. The enrolled a good number of patients, I think about 441 patients, with the mutant type and the wild type, ATTR cardiac amyloid. So it was a placebo-controlled study with a follow-up of 30 months, and the probability of survival were in favor of tafamidis than placebo. Which is a very important study, and the drug already approved by the FDA, and it's available now in many countries for the treatment of cardiac amyloid. So, in summary, AL and ATTR, amyloid light chain and amyloid transthyretin are the 2 main types of amyloidosis that affect the heart. Diagnosis of cardiac amyloidosis require high degree of suspicion. Timely diagnosis and referral to specialized centers are warranted due to high mortality without proper treatment. 99M methylation pyrophosphate bone scintigraphy has revolutionized the diagnosis of ATTR cardiac amyloidosis. And also there are new therapies now that are available for ATTR amyloidosis. Doctor does not require to know everything, but at least he needs to know where to go when he doesn't have the answer. This is the conclusion of my presentation today about cardiac amyloidosis. It's just a concise summary for the basics for those who are beginning to read about this syndrome. Cardiac amyloidosis, especially ATTR cardiac amyloidosis, Transthyretin cardiac amyloidosis, or senile cardiac amyloidosis, which I think will be very interesting in the coming few years. Thank you very much.